Attended on the 20th of November, reporting right-sided severe otalgia, so earache, and also reduced hearing. The earache was so pronounced, the otalgia was so severe that it was keeping her awake at night time. It's been very difficult for her and her mum to help her to get an appointment with the local doctor. They called the local, the national 11111 service, which we have in the UK. So you can speak to a doctor over the phone if you can't. It's almost like an emergency line in the UK. You can contact the doctor if you can't get through to your own. They obviously weren't able to look inside the ear, but they recommended Otomize, which is some medication used for outer ear infections. That was prescribed on the day before, so the 19th, and the mum and the daughter and her brother are all YouTube fans, and they decided to make the journey to see me in Leicester. So just starting off with this right ear, and it's very heavily swollen. There's a lot of edema, so that's the medical term for swelling. It's inflamed. So they have got otitis externa. You can see that the ear had been discharging. You've got all this liquid that's almost become sticky near the entrance of the ear canal. And the ear canal is so inflamed, I'm struggling to get my fine end gorge past the swelling. So at this stage, I was wasn't sure what I could do for them. Ideally, they needed to use the antibiotic spray for the prescribed period, so it reduces the swelling. So Otomize contains dexamethasone, which is a steroid, so it's an anti-inflammatory steroid, and that would have helped, but she was in that much pain that they felt that they would try and come see me anyway. So I've just instilled some sodium bicarbonate earwax drops. I don't really like using sodium bicarbonate drops when patients got otitis externa, and that's because the ear should be naturally acidic, and when someone develops otitis externa, the ear goes into an alkaline pH, and sodium bicarbonate drops is also water-based, and it is also alkaline in pH, but that's probably the only drops that could really do much in this case. Olive oil drops wouldn't really have helped. So I'm just putting some drops. I can just create an opening. You may have seen that the top of the ear canal where the swelling is. It's just a little gap now. And the patient, and her mum was writing right behind me, and she also noticed that gap, and it did make a bit of a difference to the patient instantly. Although the ear canal is still heavily swollen and there's a lot of debris, dead keratin, wax beyond this narrowing, it immediately did help her a bit. I'm just trying to get through this narrowing, so it is quite a long video, guys, but do watch both parts, because it's quite interesting, because you'll see this same patient come back 7 days later after using the Otomize spray, and you'll see the condition of the ear canal, and you can have a look and compare the amount of swelling. So again, just trying to tease some of this dead keratin from the swelling. And this is why an endoscope is so great. With an endoscope, we don't use a speculum. Speculum is like an ear funnel. It's commonly used by doctors and audiologists when they attach it to the end of an otoscope to look inside your ear. That black speculum, speculi, is disposable between patients. And it's also used when performing microsuction with an operating microscope or head loops. One of the operating microscopes is a fantastic piece of kit. It's still very commonly used in ear surgery, but so is an endoscope now. So a lot of the recently qualified ENT registrars and consultants are performing endoscopic ear surgery purely for this reason, because of the view it provides. The microscope's got fantastic magnification, but the view is very narrowed. Whereas an endoscope, it feels like you're almost inside the ear and you're looking around, you can see everything around you. Head loops, I just wouldn't personally recommend. It's what I first trained in many years ago, and I wouldn't be able to see this far with head loops. If there's wax on the outer part of the ear canal, yeah, great. And on otoscope, you can get an operating otoscope, but again, on otoscope, the view is just very narrow. It has a speculum, but you just don't get this same field of view, and it's far inferior to a microscope because it just doesn't have the magnification. So I'm just I have made some headway here. You can see I have gone into the ear a bit, past the swelling. There's a bit more of an opening. You can see now the swelling of the ear canal is more pronounced. That was quite, the view was obscured previously because of the debris that was at the entrance of this narrowing. And you'll see that a bit more obvious in a moment. So this remaining piece of debris, I explained to the patient and her mother, it was almost like a piece of dried chewing gum. It was really sticky and impacted really deep in the ear. But you can see that swelling that was referring to. That wasn't visible prior, but we've managed to get past that initial first swelling. And the patient was great. She was very still. So I just put some more sodium bicarbonate drops in there. The problem is when the ear is swollen like this, the more work you do in the ear, the more swelling you're going to cause almost, because you're working in the ear, you're touching the side of the ear canal walls, and it's just going to cause a bit more swelling. So we're just trying to do this as quickly as possible and with minimal contact. So we have made some headway. And again, the patient felt they could hear really well. Yeah, it wasn't 100%, but their earache had gone. And that was one of the main reasons why they wanted an emergency appointment on the day, because the pain was almost unbearable at night. And I can just feel the swelling getting a bit more at the moment. Nonetheless, I'm able to open up the ear canal still. I'm using a fine end gauge, guys, by the way, a standard Zollner suction probe. Yeah, it just wouldn't go inside the ear at all. So it's just a little fine end gauge attached to the Zollner suction probe. You can see I'm actually able to get the fine end into this, past the swelling, onto this piece of dead keratin and wax. That's almost like a chewing gum, but I'm just not able to remove it. It's really impacted, really embedded. You can see I've managed to clear a bit at the top there, so you can only previously see the bottom part of the swelling, but I've managed to clear some debris at the top, so the ear canal is a bit wider. And anyway, it's important that I try to remove as much debris as I can, because it allows the optimize to then penetrate past the swelling deeper into the medial part of the ear canal. There's a lot of dead keratin there as well. That's adhered to this plug of debris wax. It's stuck to the ear canal wall, so I'm just trying to get a strong suction grip. And unfortunately, with the fine end, it's not as powerful as the standard size Zollner suction probe. So again, we are getting a bit deeper in this, layer by layer, but we're definitely further in past the swelling than when we first started. Okay, I'm just trying to insert this through the swelling, so I'm just going to the bottom, and then I'm just lifting the posterior canal wall to the side, just to make some space. There we are. Whilst I'm watching that, I'm just getting a bit of slack from my Clearwax colleagues via WhatsApp. We've got a little WhatsApp group. We had a great weekend training this weekend. We had 2 cohorts, one on the Saturday and one on the Sunday. And if you follow me on Facebook, you'll see that I have been taking images of my lockdown hair first, and obviously now we're in lockdown the second time, and the guys were giving me a bit of a hard time because I can have a bit of hair at the back of my neck, and I'm quite a hairy individual. And they're just pulling my leg right now, actually saying that they're going to hold me down and pluck it with some crocodile forceps. So that's why I was turned away a bit. So I've decided to. So the patient also had an impaction in the left ear and very dry, sticky earwax. The suction probe wasn't removing that, so I've gone in with the Jobson horn, and I'm just trying to use the tip of the Jobson horn to it's almost like a fudge type of wax. If you slightly dig it in, you don't want to dig it in all the way because then you'll be dissecting this and you'll make contact the base of the ear canal. But if you embed the Jobson horn halfway in to this kind of fudge type of wax, you can drag it out, extract it out. You find that the wax behind it also comes forward. So you can see I'm really bringing this forward. And she's obviously 12, she's got a very narrow ear canal, so it does make it a bit more challenging. And there is quite a lot of cilia there as well, a lot of hair. So it's a narrow ear. Okay, it's not as narrow as the right ear, which is swollen and inflamed, but as the children, as they grow, the ear canal will get a bit wider. She's still 12, so she's still growing. And there's a bit of hair, but I've managed to pull this plug of wax and dead skin. So there's the tympanic membrane. You can see the difference between her left and right ear. That's absolutely normal, healthy. And I'm obviously just gone back to the right. So we thought, well, before she goes, let's make sure we get one. And I'll obviously soak this right ear for the last time, just to see if I can get any more out. So we're not too far off from the second part of this procedure, where the patient came a week later on the 27th of November after using the Optimize for a week. I would have possibly preferred them using it a bit longer. They had the prescription for 10 days, just to help me, because I had another video the other day of another chap who had a really infected ear canal, and oddly enough, they both came originally on the 20th of November, and they did their follow-up. They did a second appointment on the 27th. They were both obviously very pleased and wanted to come back. But for both, ideally, another 3 or 4 days would have just helped widen the dexamethasone in the drops. The anti-inflammatory steroid would have helped widen the ear canal a bit more to give me more access. With the other chap, you would have noticed on the video that I managed to, despite the ear canal still being very narrow, I did manage to remove the infected debris that was stuck on the eardrum. And I've just put a bit more drops here, just to give one final attempt to see if I can get this plug of debris out. So this is a bit blurry as well, obviously. We've been using a lot of drops, the ears are infected, so just suction some of that. So I think this is the last bit. I'm going to just be getting some keratin off. You can see some of the white keratin. I'm just going to peel that off and then mop up around the edge. And then you'll see part 2. So I hope you guys are still watching this, staying tuned. You can see the ear canal's really inflamed now. It's just really, really hard to get in there. So it's virtually closed and shut in there now. And that happens the more you work in the ear. Obviously, the ear is very narrow in the first place. It can cause a bit of added inflammation when you're making contact with the ear canal wall. So just mopping up near the entrance, just trying to get rid of some of this debris. Okay, so part 1's nearly done. Just want to see if I can get a bit of this keratin. Yeah, managed to get a bit there. Just going to mop up. So just a summary, we managed to get some debris out of the right ear canal. Could then visualise a bit more swelling, and it was getting deeper and deeper into the ear canal. Whilst the patient was here, I just managed to remove the wax in their left ear, which wasn't infected. So this is a week later, and the patient, when they arrived, they were very grateful because she no longer experienced any earache, and that earache was really causing her a lot of distress, especially at night. She couldn't sleep, so she was extremely pleased that she attended. They've been using the Optimize for a week, and from the offset, the ear canal looked very similar to how it was when she attended last week, and I was like, oh god, it's still swollen. You can see there's a lot of debris there. She did report some discharging of the ear canal as well during the week, but so her hearing still wasn't great today, but the pain went, and that was really important for her. You can see it's quite a bit of a white light there, and that's because there's some keratin and the ear canal is very narrow. Just showing it, some of this discharge is crystallized. That's what Optimize does. If you've had a bit of discharge and use Optimize, it does almost crystallize it to make it a thick crust. So I've just got past this crust is there. I'm just trying to lift it up the ear canal wall, and it's really dry, and it's causing a lot of reflection. So I'm just trying to get rid of this, get it out of the way, so I can see further into the swelling. So you can see there's a lot of dead keratin, a lot of white dead skin there, and the ear canal has widened a bit at this point if you compare it to last time. So I think I'm going to go in with possibly a Jobson horn in a moment, just to get rid of this dry dead skin near the entrance, because it's just causing a lot of reflection, a lot of white brightness coming back. So I've got a bit of keratin out there. So the ear canal is still very inflamed, but it's a lot wider than it was last time. So this is where that first swelling was last time. So this part's widened, but you'll see as I get through all this dead keratin and debris, there's another narrowing, another swelling that becomes apparent. It's very spongy debris. You still have to peel it off the canal wall. It's not loose. It's just you just can't just vacuum it. It comes out. So I'm having to peel it. And again, this crust. I'm pretty sure I used a Jobson horn just to remove. Just get out of the way. Yeah, here we are. Just to kind of just clear the entrance route for me. And it's just dead skin and dried up crystallized debris. I'm just having a good look, just analysing. It's hard to tell where her eardrum is really, because of the swelling. You kind of lose a bit of the anatomy of the ear. So most people's ear canals, you have two bands, and the average ear canal is between 25 millimeters to 30 millimeters, and you have an idea of where we are in the ear canal. But here it's just a bit more difficult because of the infection. But you can see there's a big. We can see really deep into the ear now, but there's still a bit of debris in there. So there's some keratin past this first swelling, some keratin at the base of the ear canal and around the edge. When an ear canal is swollen like this, it's a bit of an optical illusion. It seems like the ear canal is really long and the eardrum's far away, and I think that's just an optical illusion because it's narrower and it just gives you that different perspective. So again, just really gently, just trying to clear some of this debris off. Remember, the ear's infected, it's still very swollen, patient's awake, there's no local anaesthetic, no general anaesthetic, so we do have to be, at the same time, whilst we're trying to help the patient remove this debris, we still have to be gentle. We don't want to cause, obviously, the patient any discomfort. So I've just managed to release some dead keratin from the posterior canal wall. And we know it's keratin because of the colour, it's white. It's dead skin. As it dies, it turns white. And eventually it goes into a yellowy, browny, and then very dark brown black colour because of the oxidization process. So this is keratin, it's not earwax, and it's because of the otitis externa, because of the outer ear infection. There's a lot of dry, dead skin, and it's just collecting. This has probably been collecting there for a while. And just got to be careful because I still don't know exactly where the eardrum is and where the bony part of the ear canal is, and I don't want to go in too aggressively to this keratin because I might then touch the back of the ear canal, the bony part, and make the patient jump, or I might make contact directly with the eardrum. So we're doing this almost exploratorily. We're doing it very gently, very slowly. I'm always prepared to pull this fine end out the ear very quickly if I do cause any discomfort. So although I'm trying to release this keratin, at the back of my mind I'm also thinking of I've got kind of almost half an eye on the patient's facial expressions as well, just to see if it's causing any discomfort. Obviously we're bracing from the outside, so if the patient does make a sudden movement we can accommodate that, because I have got a couple of safety braces. I've got a safety brace with the endoscope hand on my left side, and also a brace on the side of the patient's cheek with the hand that I'm using the fine end with. And once more, I'm using a fine end. You can't use a standard Zollner suction probe. It's just not going to go into the ear canal. I don't know if you can see that. As I'm vacuuming, you can see the ear canal kind of closing in. Can you see it pulsing there? And that's because that ear canal is still swollen. There's a lot of inflammation, a lot of edema. So there's a lot of fluid in those cells. And when you go with the vacuum, the suction probe it's sucking this fluid that's inside these cells, and it causes the ear canal to collapse. Hopefully you saw that, guys. You saw that canal collapse because of the swelling with the fine end. The ear canal itself was pulsing a bit. It was coming in. It's being drawn into the suction probe. And I've just got this bit of debris here, so I'm just loosening this. As I was bringing this forward, it was getting trapped at the narrowing. There's quite a big piece of dead keratin here. It wasn't coming out in one go because it's larger than the narrowing. So as I was drawing it forward, it's just breaking off into pieces, which is always a bit frustrating. You just want it to come out in one big piece. And the patient's mum was really enjoying this because she was watching it live. She went right over my shoulder, but she sat behind me. She had a really good view. And it must have been great for her mum, because her mum was obviously worried about the daughter, and for her, I think she enjoyed watching it in the respect that she knew that her daughter was going to feel better afterwards. So I'm just trying to tease this. So I've advised the patient and the mum, obviously they still need some further treatment for this otitis externa, so to get in contact with their doctor again. The patient's hearing was more or less back to normal after I finished the procedure. I performed also a test called tympanometry, which assesses how well your eardrum and the middle ear, so the middle ear is made up of the eardrum, 3 tiny bones, how well that was vibrating. So just in the distance I can see the eardrum, so I know I've cleared the passage. There is a lot of debris in there still, a lot of dead skin, but I'm going to try and get in a bit further, but it was just so difficult getting into this part of the ear canal. But the patient at this point was overwhelmed. She really felt her symptoms to improve. Yes, I performed tympanometry and her right eardrum was moving absolutely perfectly. I also performed tympanometry in the left side, so we can measure basically how well the eardrum is vibrating using the test called tympanometry. It's also known as a pressure test, and both the right eardrum and middle ear and the left eardrum were vibrating symmetrically, so very similarly. So you can see the ear canal is still very swollen, and the endoscope doesn't really go in any further. I can't put it any further because that hole is too narrow. The fine end itself is got a smaller diameter than the endoscope, so I'm just trying to mop up as much as I can, safely as I can. So there's some dead skin here, but the eardrum is visible really deep in. And again, it's an optical illusion to me, and I'm watching this back, it seems like the eardrum is so far away, but it's just because the ear canal is narrowed and swollen. It just gives you the optical illusion it's in the distance. It's just there, I can see the eardrum all the way at the bottom. I can just see some of the handle of malleus, the hammer bone. the manubrium. So that's the big part of the handle of malleus, the hammer bone. You've got the big bone itself, the vertical bone, and that's called the manubrium. I could just see that in the distance. See, once more, as I said in the first ear, but the more you work in the ear, you're going to get a bit more swelling as you're in the ear, you're touching the side of the ear canal wall. So again, I think this stage the ear canal the swelling is coming back a bit. See, we just removed some dead keratin from the top, and you can tend to see that the exposed inner layer of skin there. So it's just a bit red, it's just a bit inflamed. It's not bleeding, it's not, we're not cut the ear, it's just when you've removed some of this dead keratin, it peels at the underlying dead skin. I'm just trying to really get into the ear canal there, but it is hard. And it's wobbly, it's almost like a panna cotta. It wobbles when I'm moving the ear due to the swelling. Just trying to give it one last go to see if I can get in. So for the patient now, it's so important to continue her antibiotic spray drops, any medication that she's prescribed, and keep the ear clear of water. Water will exacerbate the symptoms, so she's on the road to recovery now. The pain has gone, her hearing's come back. We just need the swelling to go, and should be as right as rain. We're nearly finished, guys, just mopping up now. So if you enjoyed that and you're watching on YouTube, please do subscribe to the channel, press the bell icon so you get notified as and when I upload new videos. I've got another great ear infection tomorrow, hopefully, if I get time to upload it. I've had quite a few recently. So there's the eardrum in the distance. I'm really pleased with the outcome, and the patient is too. If you're watching on Facebook, please do like the page, follow, like the video, leave a comment if you want to, and I hope you're all having an enjoyable weekend, and I'll speak to you all soon, guys. Take care, bye.